Happy to announce the session, Digital Health, Giving Birth to New Delivery Models Through Mobile, IoT, Blockchain, and Artificial Intelligence. As we all know, digital is making a headway into Indian healthcare sector in a big way so far. However, given the enabling building blocks, it seems that we are at the cusp of the new paradigm in healthcare sector. What is ROI? What are the unmet needs of hospitals and other stakeholders in the sector? This session will highlight digital interventions in healthcare leading to new delivery models. Happy to welcome on stage Dr. Vidur Mahajan, Head of R&D, Mahajan Imaging and Caring Research. Please join your hands in welcoming Mr. Bhaskar, Manager of Business Development, Allscripts. I now invite on stage Mr. Sharad Kumar, Engineering Director, NXP India. Mr. Jacky Ovadia, General Manager, IDEA. I would like to now invite Mr. Sayantan Chatterjee, Director and Management Consultant, PwC India. Dr. Amit Raj, Plexus Care, Healthcare Entrepreneur and a Strategist. I would now like to take this opportunity to invite Dr. Vidur Mahajan, Head of Research and Development, Mahajan Imaging and Caring Research, to present his keynote address.
Thank you so much. So I don't have slides for the keynote address because I thought, one has to draw a line between an address and a presentation. So that's why I thought I'll do this more informally, more structured as more of thoughts. Essentially, nowadays we are in the era of AI, of digital, of blockchain. Like, if you don't have an AI session at a conference, it's not really a legitimate conference. And if you don't have AI in your pitch deck, you're not a legitimate startup and all those kind of things. And we've been fortunate at Caring. So as the lady just mentioned, I run a small research group within our organization. Our research group is called Caring. It stands for the Center for Advanced Research in Imaging, Neurosciences and Genomics. We work in our very, very niche domain of literally imaging, neurosciences and genomics. And we very rarely venture out of that. So most of what I'm going to talk about will be structured around those three pillars. Also, I'll be not taking up the entire 15 minutes as I discussed, so that we can do some Q&A and maybe lend some time to the panel. When we think about developing or using or testing any kind of product in healthcare, specifically in the domain of deep science, or the other way of thinking about it is deep impact or deep clinical impact, there's a certain framework that we are working on at our group, and I'll give you like a small sneak peek into that framework. The idea is that, and just indulge me, right? So I will do a lot of hand movements and just try to like follow around with that. So when you're developing, when there's any product that comes to the market, there is effectively, you have to develop it, you have to test it, and then you have to deploy it. Right? So there is development, which is the actual process of making the product. There is testing, where you have to make sure that your product actually works. And then there is deployment, which is possibly the most hardest part, which is actually getting your users to use that product, right? One would assume that good product gets used by users anyways and vice versa, but as we've seen with many examples, it doesn't really happen that way. So product development, right? Many people in this room, or let's do show of hands. Who here is working on making things? Anyone here? Okay, thank you. So I have quorum. So whenever you're making a product, or many people in this room would be getting approached by people asking questions around, hey, I'm trying to make a AI product for healthcare, what do you think I should work on? Right? I think that's possibly the most common question being asked to doctors nowadays. You'll typically get two types of answers to that. And as a product developer, you need to be very, very wary, because we give both types of answers, because we get approached by a lot of people. The first type of answer is, once in a while I get this really, really difficult patient, who has like, I fail to figure out if it's a oligodendroglioma or if it's a glioblastoma. So, or it's an astrocytoma. And I would love to figure that out on a brain MRI. So that I don't really need to do a biopsy. So, can you, Mr. Data Scientist or Miss Data Scientist or product developer, can you make a solution for this? Right? Amazing use case, can we get to histopathology from MRI, right? It's like the holy grail for imaging and all of that. So the data scientist goes out, they start working on stuff. First, they'll try to figure out, oh, where do I get data from? That's an entire journey in itself. And then they finally realize, they make the algorithm, it has like 90% accuracy, sensitivity, specificity, whatnot. And then they go back to the doctor and they say, now we have the product ready. And doctor says, amazing, I will use it. And he has to wait 3 months in order to get that one case where he's actually confused between whether that patient has a oligodendroglioma or a glioblastoma or an astrocytoma, right? So essentially you went out there, you built an amazing product, but you built it for a use case that happens once in a blue moon, and the incremental value add of that use case is not so much that the person's willing to pay ₹1,00,000 for it, right? Because they can do a biopsy, because they'll anyways have to do a surgery. So that's the first trap I see people fall into, where they go out, they develop really, really specific use cases, which is great to develop, but then those specific use cases are also rare. As opposed to the other example, where we are trying to push a lot of our collaborators into, is you develop something that is useful for every patient that walks into a clinic, right? So 50% of all chest x-rays, for example, or if we stick to the brain MRI analogy, 40 to 50% of all brain MRIs done all over the world are normal nowadays. There is no significant finding. But one still has to look at those images. What if there was an AI tool that could sift through all the normals? You would be useful in every other case. 50% of MRIs done all over the world would be your total addressable market, right? So, just think about this thing whenever you're especially when you're giving advice, right? Because very credible people in this room, whatever you tell a startup, they'll spend money, time, effort, building that out. But be very wary, or when you're hearing this feedback, be very wary of how frequently is the problem encountered. Then the second thing is, let's say you've developed a product, right? Now you have to test it. Now, the fundamental difference between a healthcare AI company or a clinical AI company and say a company like Uber or Ola is that when Uber made the app, there was really no question of whether the app would work or not, right? If GPS works, then the Uber app works, right? The question is more around whether the consumer will adopt this, what is the pricing, what is the market, and all of those things. So fair number of challenges. Whether the app will work or not was not a challenge. When you're dealing with healthcare AI or healthcare products, the first question you have to figure out is, does my product even work? Is it even picking up the normal, abnormal brain MRI properly, or is it even making the diagnosis correctly, or whatever your domain might be? So it's very important to test. Now, there are two ways of testing any healthcare AI product. Again, so we were here, we were developing, now we are testing, then we will deploy, but within testing, there's two ways. You can do a retrospective testing or a prospective testing. Retrospective testing, as the name suggests, is you go to a hospital, you pull out whatever old data. Let's say, you are trying to predict mortality from a ECG, right, which is a new paper that has come out. It's crazy, right? You can do that apparently within statistical bounds. So You pull out a bunch of data from a hospital, you pull out say 5,000 ECGs, and you have, whether those people lived for another year or not. You run your AI model on those ECGs, and you try to see how many times does your AI model go wrong, right? Because all we care about is why are we going wrong or when are we going wrong, right? Because that's most important. So that is retrospective testing. Prospective testing is you actually give it to Dr. Amit, right? You say, sir, now you start using it in your clinic. The first thing he'll say is, Acha, how do I use it? You'll be forced to figure out a lot of those issues. Oh, my ECG reading is blue, but you trained it on black and things like that. So that's prospective testing, and then you actually follow up those people. And the cool thing about prospective testing is that if somebody, according to AI, is going to die in the next 1 year, you tell that to the person. You say, hey, if you don't figure your life out, you are going to die in the next 1 year. You have introduced what is called a confounding factor, but then if the person lives longer than a year, you're happy at least, the AI helped in some way, but that's like a not so good example of a prospective study, right? So we were here, we were developing products, we have to develop products that are relevant, that are useful more often than they are not useful. Then we come to testing, we could do retrospective or prospective, and now we are convinced that our application actually works, right? And now we are ready for the Wild West. We will go in and deploy in hospitals, right? So you reach the hospital. First of all, generally you will find some relative or some connection or whatever, or through InnoHEALTH, you will bump into people. You will reach the hospital, and they'll send you to the IT department, because obviously all sorts of this stuff relies on IT integration. And once you reach the IT department, the first answer you will hear is, we don't share data with other people, right? Or we don't have APIs, or we don't have integration policies and stuff like that. So then you'll go to the CEO, you'll try to figure out all of these things. So, but to cut a long story short, when you are deploying, you'll be able to deploy again in two ways. The first is you will say, here, for lack of another word, screw the hospital, screw the IT department, I will simply make an application and give it to the doctor to use, right? So you create like, again, ECG AI for Android, right? And doctors start downloading it, they click pictures of ECGs and you're reading them and all sorts of stuff happens. Maybe that's a good use case to go after, I don't know, a lot of ECGs being done. But that's one way of doing it, where you say that, okay, I am a standalone deployment, my product only does this, but it does it really well, and Mr. Cardiologist or Miss Cardiologist, please use this application, right? Perfectly legitimate way of deploying. You need to be very wary of the fact that, how well it works or not, because the problem with going to the experts directly is that if your product doesn't work, they will go to conferences and kill it, right? The second way of deploying is the more integrative strategy, right? Where you literally go into the hospital and you say that, okay, how can I link my software to the actual ECG machines and the EMR systems, and the HIS, or in radiology, RIS, PACS, etc. All sorts of, you'll come across all sorts of TLAs, three-letter acronyms. So that's the other way of doing it. But the only thing I can say is create incentives for people to want to use your product, right? Because if you do part number 1, development, and part number 2, testing, really, really well, then even if it involves the IT team to open up that API or to, do whatever the hell you want, they will do it simply because the clinicians are going to ask for it or the patients are going to ask for it. So with that, I'll end my address by just saying that if you have a product that is useful, so the development part, that works, that's the testing part, deployment is not going to be a problem at all. Like, adoption is not going to be a problem. Everyone goes around saying doctors are very averse to using AI, or doctors are very averse to using technology. You look at the amount of consultation that happens over WhatsApp, you will be shocked to see how doctors are good at adopting things that work. So with that, I thank you all for your patience. Thank you.
Thank you, Dr. Vidur Mahajan. May I now ask Mr. Bhaskar to moderate the session on digital health.
Dr. Vidur, thanks for setting the tone on digital health. And the topic here is giving birth to new delivery models through mobile, IoT, blockchain, and artificial intelligence. When you think of on-demand, you think of consumers who want things at their own convenience, on their own time, and wherever they happen to be. The healthcare industry is entering the era of digital innovation as patient seeks on-demand healthcare because of their busy schedules. People have simply become more mobile in the past decade. Mobility is the name of the game. And the recent statistic shows that more than 50% of web browsing in the world occurs on mobile devices, as on 2018. To be precise, it's 52%. Good afternoon, my dear guests and my dear distinguished panelists. Myself, Bhaskar Motouru, currently working with Allscripts as an engineering leader. I have been in healthcare for the last 15 years. I enjoy developing new softwares in healthcare. Now it's time to quickly introduce our panelists. So he is currently an engineering director at NXP. He has been a technologist for over 20 years, primarily in semiconductor chip design, with work stint in United States and India. Also published several journal articles. His recent interests are in machine learning and healthcare. Over the past year, he has collaborated with several dermatologists, particularly at AIIMS, New Delhi. He is Sharad. He is an experienced expert in international innovation and business development. He is general manager of IDEA. He comes from Israel to establish collaborations and innovation centers in the field of personalized medicine in cancer with innovative decision support system for the diagnostics. And he is looking for partners in India. He's also the founder and CEO of the Wellness Tech Forum and the chairman of International Conference, Advanced International Medicine. And he is Jacky Ovadia. He is a cardiologist by profession with various roles in healthcare environment, from clinician to administration, and now healthcare entrepreneur. He believes in driving innovation to deliver value-based cardiac delivery. He is Dr. Amit Raj. He brings a blend of business and technology through his varied experience. He specializes in leading technologies-enabled transformation through digital operating models. His active interest includes emerging technologies like blockchain, IoT, artificial intelligence, machine learning. He is Sayantan. All right, so we're getting to start this session a little differently, although it's as a panel discussion. We will start with a presentation by Jacky, and we'll also end with a presentation. So Jacky.
Well, good afternoon, everybody, and thank you very much. I should take you home with me because it sounds much better when you present me like this. Thank you. Well, first of all, thank you for the organizers, and thank you for empowering this panel especially, because when you read the name of the panel, it's really funny. Now you can understand why India loves children so much. Invitation for give birth for new delivery models. Okay, so we speak about IoT, so I was presenting about IoT. I took some things that we are doing practically in Israel. I used to work I'm working in health business in Israel more than 20 years. But the last 4 years, I was working for Clalit, which is the biggest HMO of Israel. Israel is a mandatory insurance. Whenever you get born, you have to choose an insurance, and you get everything for free. If you need premium, you can buy premium. But all of the citizens are insured. So it's a part of the dreams you have about Ayushman Bharat scheme, and we're going to host a team from Ayman Baharat in this November. I'm into hosting them as well in Clalit. They would like to know who is getting what, how, what is the health basket includes. So from that point of view, I would show you some ideas we have here. I have 2 videos, but the basic idea is to have a digital continuum of care. Continuum of care is the gold standard for physicians. What you do at home, what you do with the clinic, with the family doctor, what you do in the surgery room, so everybody can use your health medical record, read what you had before, look at your history, and if it's digitalized, so you can use AI and machine learning and to have supporting decision methods to support physicians or any other clinicians. So this is the idea. It's very high clinical quality because of that. It supports people to stop making mistakes, or you can learn faster from your mistakes. And it's about maximum efficiency because Israel is investing something like 73% out of the GDP in health, private and public. India, I think it's 4.3, fix me if I'm wrong. But in the United States, it's about 17% of the GDP. So, but the measurements for health in Israel is much better than the States, how it comes. So about, just to get remembered, so we're speaking about global digital health or digital health. It's about remote monitoring, it's about telemedicine, it's about health, and about healthcare IT, everyone with his own domain. So about, let's say, telemedicine or Clalit, we were the pioneers to implement telemedicine in our clinics. It started at the year 2009. The online services were including family doctor. You can hold your phone, speak to him, and get answers. He can watch you, you can watch him. And then we had implemented skin doctor. And then we implemented a child development application. And then there was Care, which made a big change. Who of you heard about Care? Okay, you would see it in a minute on a video. And then there is day 2, and the future is coming up. It's about AI for skin doctor. It's portable ultrasound for the pregnant woman, and on and on. Let's look what Taito is. It's speaking in Hebrew, so I'll do, can we hear just a little bit Hebrew? So welcome to the clinic. You used to feel bad, so you came to the clinic. Now you don't need to come. You can use this machine, and you can look at the screen. But synchronically, the doctor also can see this screen. Can I hear a little bit? It will be easier for me. And then they can check 7 measurements, also saturation, also pulse, also temperature, also to look in your eyes, nose, ears, and on. And the application guide you what to do, how to do. It's cost about $300. You can have it at home, and it saves you then running to the hospital. Now, when a patient of Clalit gets to the hospital, we as Clalit pay about 1,000 shekels. So we save a lot of money. Can you skip this one? We'll go to the other one. So one of the questions for this panel was, does it worth it? So if Clalit is spending for those patients who go to the ER at night because they didn't have a physician, we spend about $60 million a year. But investing of implementing this machine cost us about 5, so it's very beneficial. It's bringing us into save 1,000%. 1,250% a year. Or regarding the dermatologist, skin doctor. We have a skin doctor application here. And it goes like this. It's very hard to get a line to a skin doctor. You have to wait for about 5 weeks. But if you are considering that you have a melanoma on your skin and you're really frightened, so you can take a picture of it, send it, and synchronic or asynchronic, you can have an answer. And it's really proved. It's like we have the FDA and regulation and everything, and you get an answer, so you skip the need of to go to the doctor. It saves a lot of time for the doctor, and it's cut the lines. So it's an excellent marketing tool, and it's an excellent tool for preserving customers because it's better service. So it's like this with monitoring, like taking Holter home for heart. It's doing ultrasound at home. It's also AI about reading pictures like Zebra Medical. Who have heard about Zebra Medical here? So I would suggest you to read about it because I think the next thing they're going to do is work about tuberculosis here in India. It's automatic machine that do radiology. The same with pathology now. So remote monitoring is a concept that was also being implemented in hearts. It's a program of rehabilitation of hearts. Somebody had, let's say, a catheterization or a bypass, and now he's having a Xiaomi, and you have a trainer working with him, a dietitian that guides him what to do, and you have to go back to his life. But they also supply the IoT device, which is a wearable, and check his pulse. One of the crazy things that happened, that they take all of the information about the guy, and the adherence to make him do things is controlled by a call center that check what he's doing, check the GPS, checked his watch, like if it's Fitbit or Apple, tell him you didn't done your exercise, you should do better. They do it with a chatbot, and it's personalized, like, did you had your meal last night? Yes or no, and things like that. Did you drink enough water? It's about adherence, making people do the change. Now, what's happened with this guy, we saved his life because he was wearing this wearable with 12 lead stamps, and we saw that there was a problem with his heart. It was in the middle of the night, and they sent an ambulance to his home. He didn't know nothing, and we took him to the surgery room. He had a terrible ischemia. If he wasn't being monitored online, he would die. So it's not only for that, it's not only about money, it's also about saving lives. Let's look at this, digital urine test. You have many patients with diabetic problems, they have to do urine tests, but what you do today, you have to go to the clinic to do the urine test. Nobody do that, or most of them don't go and do that. So it is better to send him some kits. He can do those at home. He can pee in this small cup. He can dip it. He can take a picture of it. And it's being as part as his health medical record. So then you don't miss any gaps of information. Another thing, we were speaking about health medical record. We were speaking about special clinics. You see the device on the left? It's a very stupid computer, but it's being very prepared for the field work, for the army. It's an iPad. It's very secured, not with blockchain, but it's secured. And it's a closed system, so nobody can penetrate it. And the physician that you saw on the side with the soldiers waiting in the clinic can walk with this out and can serve as a clinic. But he can take it in his bag as well with many devices, and he can supply it from anywhere to anywhere. And this is implemented also now in many of the armies that we work with. And this is amazing. This is real AI.
When patients receive a warning from their doctor about their medical risks and how to prevent them, they can be so overwhelmed with all the difficult changes they need to make, they usually just give up on even trying. Ideal Health, our AI-based, data-driven app, helps individuals focus their efforts and supports them and their care providers into taking action. Using individualized medical data from the electronic medical records, one can visualize a personalized risk for multiple diseases and potential improvements by visualizing the effects of modifying risk factors. As opposed to other online calculators, our advanced causal inference algorithms help to demonstrate how the risk changes if the individual accomplishes different goals. With Ideal Health, individuals perceive that the risk is real and are empowered to best choose which goal to pursue according to their preferences. The patient's provider receives notification of their selected goal, as well as action items to approve, like a prescription for medication, referral to lab tests or support groups, and follow-up visits. The referrals are automatically sent to the pharmacy, test labs, or support group, and notifications are included on the patient's calendar. Ideal Health helps the patient to better understand their medical situation and how to take action to improve it. All with the support of their medical data, medical provider, and medical team.
So in Israel, everybody can move from one clinic to another, one HMO to another in a day. You can do it through visiting in the post office or in the net. So the fight between 4 HMOs to keep their patients with them is about giving better service. So Clalit is collecting data since 1980. So they collect data from the clinics, and they control 53% of the market. They collect data also from the hospitals. I used to work there, so they own 30% of the acute beds of Israel. So if you collect all of this data on the same platform, you can see strange things happen. We spoke about AI. So what is the connection between a bad refraction of seeing not 20/20 to osteoporosis? One of the answers that algorithms said to us, or any research said to us, that there are many people that don't see so well that they have problems or risk of osteoporosis. We take those samples again and again, and it's the same answer. The computer says there is a connection between those two. So how it comes? So if you're a physician, nobody would tell you there is a connection between eyes, ophthalmology, and bones, broken bones. How it comes? So we discovered that the robot or the computer saw that those who can't see that well can fall and break a leg, and that's why there is a connection. As a human being, we wouldn't have thought about that. So the computer or the data help us see a lot of things from different angles. So coming soon is urine microbiological urine test that check new proteins that can put your tell that you're having a risk in your kidney and save you as a kidney patient and save us a lot of money than not letting you get to the dialysis so soon. Or it's about ultrasound for pregnant women. If you remember that the first pregnant, I can feel the baby, I can't hear the baby, so the women implemented themselves. So think about the physician or the gynecologist that escort this pregnancy. Would you love this machine? No, he wants her in his clinic. So there is a big fight who do what, and the idea is how to make it happen and to work together with the physicians to implement it. Now regarding why I'm here. So it's very simple. The same that there was here with Japan, which is amazing, there is with Israel. There is a call, an open call to do research together, to do collaboration together, and that's what I'm doing here, especially regarding cancer. I'm here to find a collaboration team to work with cancer patients, especially for those 2 breast cancer. This is this month. And the team I'm working with is a team that works in Israel and America. It's P8 medicine team, P for precise, personalized, predict, preventive, portable. It's the next AI for treating cancer. Mostly it's about collecting data from many sources, and the more data you're going to have, the more protocols you're going to have personalized to the patients. Because if you check, you find that the modern medicine let us make mistakes for 30% of the summaries of the doctors are wrong, or the medication we take, we don't have to take. We know that. The question is which 30, what to stop. So this kind of working out with physicians from all over the world, from mostly America and Israel, and the data, the scale you have, I think in India, there are about 3.3 million cases, new cases of cancer a year. So the scale of India and the good labs you have here, I think this is a very good power to make new innovation. So my idea, services for those kind of collaborations is about building hospitals in Israeli style, digital style, building digital platform, training physicians, technicians, nurses in Israel, or doing master classes here, and also building innovation centers. We collaborate with all of the famous hospitals you know. We collaborate with all the HMOs in Israel, with the Ministry of Health, of course. And we did some projects in building hospitals. This is in talking of building this hospital in one of the regions here. It's called the infinity model. It's about how to get to infinity through health. So our mission is about, we are passionate to share knowledge and to learn together. But when you speak about those talks, you probably have to come with your pockets full. So if you have a dream about digital health, about new things, about building new hospital with Israeli style, we can find a way to finance it. We do that. We are now working on 4 projects like here. So we invite you at the break so we can find full financing for any of your dreams, which you have a business plan that would work. So the last sentence is, which is very close to India about, let's say, digital health, is you have to decide if you are the locomotive of moving things forward or you watch the train leaving the station. This is about digital health. Thank you very much.
Thanks, Jacky, for sharing lights on remote disease monitoring and continuous monitoring and telemedicine. I have a question for you. How does regulatory come into picture if the doc makes any mistakes using the telemedicine?
What is, sorry?
How does the regulatory comes into the picture if doctor makes a mistake using any of the apps that you have shown in the video?
If you're using an app and you have a mistake,
Yes. If a physician makes a mistake,
yeah,
how does regulatory comes into the picture?
we kill him.
That was a short answer.
Seriously, I'll give you an example. We were speaking about automatic radiology. We have learned that in radiology, there are 40% mistakes, not seeing things that you could see. Let's say that you have a spinal problem and you send your patient to do a CT. And then after some years, he got a cancer in his lungs. And then he go back and he see that in this CT, you could see the stain and you didn't. So it's your mistake. It's your, as an HMO. So there are 40% mistakes like this.
Okay.
But the machine, the AI machine covers it. They would look at the lungs because you as a radiologist, if you listed the spinal, you would look at the spine. You wouldn't look at the lungs.
Okay.
But the machine do that. So they pop up with all the problems. So it's about a safety net. It's not about making you wrong. It can give you the permission to choose. There are some options. So it gives you the options, and you are, as a physician, would have to choose because it's a machine. The robot doesn't replace the man. This is the important thing that physicians that are here have to know. It's like a new tool.
Okay.
The robots won't do the surgery. The Da Vinci is not doing the surgery. The surgeon do that.
Thanks, Jacky. We'll move on to the next question. Sharad, what are your thoughts on ROI of digital intervention? Do you have a proven case study for implementation?
Thanks, Bhaskar. So maybe a quick introduction to what I'm doing. My background has all been in technology and semiconductor development. Over the last couple of years, though, we have been kind of figuring out AI is kind of at the border of hardware and software systems. How we could use some of that technology that I've been working on in multinationals and use it for betterment, particularly related to healthcare. And we came up with dermatology because it's very widely prevalent. The market size is huge in terms of even India. I think it's about 8,500 crores, growing faster than maybe even diabetes, even in a country like India. And also because I think the disease varieties or specialities or subspecialties within dermatology are several in the sense that there are many, many kinds of different diseases. So it is very amenable to AI. And the general practitioner accuracy is very low in terms of diagnosing skin diseases, below 50%. The number of trained specialists is very low. I think, as Jacky kind of mentioned in his sort of speech as well, that even in Israel, you could have a wait time of 5 weeks or longer sometimes just to see a dermatologist. The other aspect that we considered, primarily as computer scientists and not coming from medical profession, is that the fact that what is the entry barrier? And many of the skin diseases, particularly in the way they manifest in our country, they are not life-threatening. So we felt that the entry barrier in terms of doctor adoption is going to be lower. So those were the kind of things we considered in terms of doing this. Then we contacted some dermatologists at AIMS, and they were very happy to collaborate with us, signed an MOU, and started working on this about 2 years back. Today, we have a mobile phone application which, based on a single image of the lesion, you take a picture through the app, maybe do a little bit of adjustment, like zooming in, because we are not using any additional hardware to, like a dermoscope or anything else. You kind of isolate the lesion area of interest, and 40 diseases, we have a very high sensitivity of about 85, 86%, very high specificity of about 97% in diagnosing 40 of the common skin diseases. Quickly on to like maybe more directly relevant to your question. I think some of the technical challenges in any AI system, not just related to dermatology, there are two. One is kind of what are the kind of algorithms you are using, or the kind of foundation in terms of AI that one is using. And the other is sort of, or maybe there are three. The second is probably the access to data, or the kind of data that you have access to. And the third, and I think Dr. Mahajan referred to it, is kind of the foundation of clinical trials. So taking those three things into account, what we have encountered is actually that algorithms, I mean, we have, or I have, and some of my partners have strong algorithmic background. But today, the world is, or the software world, is very, very good with sort of open source, which is kind of publicly releasing some of the newest algorithms and research, especially out of the big universities in the US, in other parts of the world. Even big organizations like the Googles, the IBMs, the Microsofts of the world are very good with publishing some of the work that they are doing. And in many cases, you can find some sort of implementation in terms of code for these. So the starting point in terms of, because you may know certain algorithms well, even in machine learning, there are very new algorithms, new kinds of algorithms keep emerging. So you have to keep up with the latest, and some of the ability of these universities to do research, or the Googles of the world to do research, is far greater than what one can do with a few people on a shoestring budget. So therefore, this sort of revolution in the industry in terms of open sourcing thing gives us the advantage that you look at the research paper, and then you are able to identify certain novelties that they might have, adapt it to your area of interest, and then incorporate it into your system and very quickly try it out. The other thing with regards to data, I mean, I think there were several speakers before me in the previous panel, which in a very organized part of, let's say, parts of Europe, et cetera, they're very well organized, and the data is very organized. But where I think we have benefited firsthand is that just the large number of people in our country lends itself very well to providing data for data sciences. So because of our MOU in AIMS, which is seeing about 500 dermatology patients in a day, the volume of data that we can collect or the size of the clinical trials that we can run is enormous. And these are the studies that are conducted in other parts of the world. We have been very quickly able to get ahead of them, both in the size of the data collected and the size of the clinical study. We were able to complete a 3,500 patient study, clinical study across AIMS New Delhi, across AIMS Rural Outreach Center in Haryana, and a couple of upscale clinics in Gurgaon in a matter of like 6 weeks, right? Which is probably impossible in any other or most other countries of the world. So that is the advantage that we have had. Some of the other challenges, and I think maybe alludes to your other question as well, has been regards to regulation. And I think the regulation is maybe not as well structured in our country. But certainly, I think even in the case of dermatology particularly, the FDA, which is probably sets the bar in terms of how regulations are governed in the rest of the world, we have found that anything that a doctor can interpret, and this is a sort of layman explanation, that anything that a doctor can interpret directly, and the machine is also interpreting it directly, that means there is no inference involved from a doctor point of view. It's not some non-human readable format. Then if you're offering a decision support system to a doctor, which is what we are primarily saying, that we are not saying, let's replace the doctor or let's get rid of him, he's no longer needed. What we are saying is that here is a solution which is available on your mobile phone, which can act as a decision support tool for lots of people who do not have access to good dermatologists, or for good dermatologists to get a second opinion on. So the way the health laws are evolving in the rest of the world is very progressive, and I am hopeful that India would kind of follow the similar things. So that's one aspect. The third aspect is probably more related to the business model of things and how do you commercialize the solution. We have looked at a number of aspects. I mean, I think the feedback of doctors was essential. So certainly there is a spectrum of doctors who kind of felt that, yes, it would affect their jobs and other such things. But I think, and that's a sort of a natural reaction. And I think one has to show with clinical trials and with more education and with maybe more seminars that really AI, as it stands today, for maybe, except for maybe a couple of isolated diseases which are very amenable to AI solutions, they are largely an augmentation system for the health practitioner as opposed to a competition for them. The other thing which is maybe more specific to India is the idea that a lot of people who practice medicine are fakes, and a lot of doctors alerted us to it and kind of wanted to say that a system like ours in the hands of people who are not trained would further augment them and make the Indian system weaker in terms of following the rules and other such things. So that was something that we were very careful about or wanted to abide by. So rather, from a business model point of view, to keep it short, I think we have largely been, rather than trying to get to doctors directly, we have been focused on a business-to-business model. And I think we decided to work with a large pharma who's interested in licensing our product and then providing it through their extensive, it's a global pharma, so through their network, provide it to a large number of GPs within the country. So I have found that India in particular, I mean, I think the laws may evolve, etc., but I think by and large, the progressive nature of, and the other part, which I kind of missed, and this is part of any kind of scientific technical endeavor, what we found out was that not only are we good with skin disease diagnosis, we are also very, very good with oral cancer diagnosis. Now, oral cancer happens to be a particular problem which has very high impact in India because of tobacco consumption in the rural areas. So we found, and we are working with foundations like Wish Foundation to try and take it out to the primary care so that healthcare workers or primary clinics can actually also do an initial level of screening and triaging for things like oral cancer besides skin diseases to be able to raise an alert to where intervention is needed by a doctor, but screening can be done by healthcare workers. So I have found both the NGO network and the research network in India, primarily through AIMS, and the wide abundance of data to be primary drivers, which I think though we have some way to go in terms of market commercialization and other such things, the last 15, 18 months have been very, very enjoyable. And I think it has been very good to kind of work with all of these people to kind of enable a technology-driven solution, especially coming from primarily a technology background with maybe only skin-deep knowledge of healthcare. It has been very good to work with all of these partners to enable these kind of solutions in India. Thank you.
Thanks, Sharad, for sharing the case study on dermatology. And wish you to explore more disease categories and build more digital solutions. So the next question is to Sayantan. So how do you look at the Indian market for the digital healthcare?
Thanks, Bhaskar. So I think thanks to everyone on the. Okay, thank you. So thanks to everyone on the panel in terms of getting that right perspective, because the first question that which caught my attention was that when we are looking at, and thanks Dr. Mahajan for putting that when I'm looking at a startup, when I'm looking at a technology, when I'm looking at AI, and it's like, is it just a buzzword? Or is it something that is really useful to the community? So just to introduce myself, so I work with PwC. So where what we try to do and with our clients, with our communities, as we say, is trying to just not look at it technology as per se, but try to look at technology with a business view. So not just looking at something which is as a solution, but how is it relevant? How does it work in the present context, the context of society, the context of the business, the context of the model that you're looking at, and very importantly, it has to be something which is one of the things that we're discussing in terms of the model, the service delivery model, and how is it sustainable. So that's what we try to work with clients, I would say, and our stakeholders across, I would say, in terms of the industry. Now coming back to the question, Bhaskar, that you had in terms of how do I look at digital in the Indian context, I think it's basically at the intersection of three things that we are looking at. One is healthcare, and which is primarily what like our honorable Prime Minister and I think all the government is saying is one of the critical sectors which is needed for any country, and India being no different, to be really have like a healthy society, because healthcare and education is what is going to build a society. So that's one. Secondly is digital. If you look at it in terms of, and there is a lot of things, what is digital, what is tech, is it cyber, is it IT, is it technology? It is really looking at, I would say, using all the power that we had as India, which we traditionally have enjoyed for the last 20 years, and thanks for all the silicon or our own version of Silicon Valley. So which we always had, and using those prowess to use it for a sector which is one of the key things that I was talking about. And third, most importantly, is that we are realizing now is that with the traditional delivery models that we have in healthcare, there's so much that we can build. There are so many hospitals that we can build. There are so many doctors who can reach to the last mile. There is so much that can be done by the ASHA and the Anganwadi workers. But what technology and what mobile, in fact, that is one of the key things, and I'm sure all of us in the room have seen that, where you go to a rural India, there may not be electricity still, and I'm talking about 2019, but you'll still have a mobile connection with maybe a 2G or a 3G or maybe even a 4G connection. So what it tells me is that maybe that as digital, and digital I'm using interchangeably with mobile, with in terms of technology per se, is the reach is there in India. It has that power of reach. Secondly, it has the power of basically transcending any language culture barrier. Think of it like any app that you think of, any, I would say, marketplace or online marketplace, or any communication that you do, it is typically independent or breaking off any culture. So that's the third thing, which is in terms of, so what digital provides in India is breaking this, I would say, and also, I think, sorry that I missed this, is the entire rich and poor divide. So a person who has a mobile is as good as anyone who has another mobile. I'm not talking about the device, I'm not talking about the plan or the postpaid and all, but talking of the reach, talking of the accessibility. So digital is what provides in an Indian context that means. So in terms of, I would say, a long, I would say, the way that in terms of answer to that is that it provides a means to something as critical as healthcare, a carrier, a means, which has been missing and which is now the opportunity. And I'm saying not now, it's been, I think, and very well said by Jacky, it's like we can choose to be, I would say, like a person who gazes or the person who catches on that train. And that's what heartening to see is that when we work with a lot of startups. So in PwC, we incubate, if you would have heard of T-Hub, that's a Telangana hub, that's incubated by PwC, where we work a lot with startups. And the first rule in working with startups is that I don't work in these jackets and all. It's wonderful ideas. So we work a lot with those ideas, and those ideas are coming fresh ideas. I'm talking about people who have just graduated, people who are just, sometimes like they're just maybe graduating or just into studies and all. But they come with these fresh ideas, and which then freshness, what I'm talking is the context. So I'm not without naming that person, I'm saying this is a person who came from the Northeast states, and he came with the same concept of what we have the mobile app in terms of how can it give the vital stats and all. And he said in a Northeast context, there's a lot of humidity in the state that I'm coming in. The sensors, if you would have seen your mobile, the sensors typically doesn't work when there's moisture on it. And he has come with a small device. It's like just dries it up, that sensor, and it's working for this context. So would you say it's like it's a frugal invocation? I'm also using the word that that was mentioned before, that in terms of being frugal. So these are the fresh, frugal Indian ideas. And why India? I would say Bharat ideas, which is what's happening right now. And I always keep on saying, we can always get inspired by the West. It's always good to be hearing. But ultimately, what's working in India is the entire Bharat concept. And that's a lovely thing that's happening right now. And I'm really honored and privileged. Being in PwC, we work with a lot of these, where what we do is, typically, we do not look to any way make those ideas stale. But what we try to make them is that, is the business context right? Is the model going to be self-sustainable? And that's how we are working, and that's across multiple use cases around digital. And happy to, I would say, take a few of them as well. Thanks, Bhaskar.
Thanks, Sayantan, for your expert comments on this. We'll move on to the next one. It's for Dr. Amit Raj. How the AI and IoT-based solutions will save the lives and make the difference. Do you have a proven case study to share with us?
Yeah, I do have. I mean, that's what we've been doing in our company. I mean, I would like to,
Sure.
Friends, I'll just take 10 minutes of yours. That's it. I think just lunch session. Everybody must be hungry, though. I'll just take 10 minutes. Well, Plexus Cardiac Care, I mean, by the name suggestion, I mean, cardiac care is more into cardiology, interventional cardiology. We use our own innovative thoughts, and we have put into a excellence performance program in cardiology, right from rural world to the international tertiary care hospital in Tier 2 and Tier 3 cities. So, and our technology is branded by the name Medi360, and the company is Plexus Cardiac Care. So simple, we transform acute cardiac care. So it's a end-to-end, affordable, accessible heart care. We reach out to the last mile through IoT and AI-based solutions. Well, coming to the last mile. I'll just give you a brief example. What are we doing in last mile? Last mile is the last village where there are no doctors available. I'm sure most of you would have come out from small towns, villages, towns with your ancestors living in these small villages. Quick question, where they getting access to any doctor? What happens if there is a heart attack? We just say, chest pain. What do we do? So that's the need. And with the government schemes and with innovations, with IoT, we thought, let's bridge that gap. I'm an interventional cardiologist, and we thought, yes, so that's an inspiring, motivating factor. How do we take a cardiologist to the last mile when there are no doctors available? This is a simple IoT healthcare ecosystem, which I think everybody is aware of it, and then most of you are, reading these, and I'm sure everybody acknowledges. IoT is used in customer feedback, monitoring devices, patient care at home, distribution, manufacturing, R&D, healthcare, blah, blah, blah. Is it going to create value to the healthcare which we are looking at? Yes, it does create value. Does it create an impact to the society? Yes, it does. Does it create a business proposition? Yes, it does create. Does it help in the economy? Yes, it does. I'll explain to you later. Well, this is a simple financial market of how IoT and AI is driving the investments across in this sector, which is phenomenal. Example, remote patient monitoring market to surge beyond 1.4 billion by 2025. HIS systems, 53.2 billion opportunity. The technology segment of market share will be about 77%. So this is the basic financial numbers which the institutes are looking at investments. This is a simple example where somebody has a chest pain. Example, they're driving their own car. The car system is enabled with an IoT GPS model system. It can guide you to the nearest hospital. It can track your updates. It can inform the hospital close by to you, yes, this is the nearest hospital. Google can tell you, yes, this is the nearest hospital, please go there. So these are the newer innovations which IoT is helping us. Simple IoT, which connects anyone, anytime, any place, any service, and at any network. And AI programs that performs data model, train the model, and provide diagnosis and make recommendations to the physicians and the clinicians. And AI only assists in making decisions. Well, this is about our company. And we've been doing this for the last year and a half. We have our rural clinics in deepest part of Bihar, somewhere close to 7-8 clinics we've been running. In Chhattisgarh, about 10 odd clinics. Gujarat, we've started with 4 odd clinics, and coming up shortly in UP, Karnataka, and abroad. So overall, about 25 heart clinics and telemedicine AV centers we've been operating as such of now. Well, what is the problem in a smaller tier 2 city? Patient comes with a basic chest pain, early symptoms may be ignored because he's not aware. He goes to his physician in a small town, and the physician recommends him to go to a hospital via an ambulance. Ambulance must or will be having some basic, cardiology monitoring devices with them, and the patient goes to a heart hospital, and he's intervened. Well, 90% of our cardiologists are in urban and tier 1 cities, and which makes a heart specialist available. So you're safe. You're early intervened. And a medicine or intervention is done and you go home. What happens in a rural physician? Absence of medical device, expertise to detect a heart problem. What happens? The physician just prescribes medicines and tells the patient, please go to another hospital or to the nearest city. No specific cardiac ambulance available. But now, I mean, things are changing with 108 ambulance getting to the last mile as well. But again, there's a gap. Medical professionals available in a small village. Patients may either be treated heavily or lifelong, or they may die due to late diagnosis in a small village. And the heart hospital is about 50 to 100 odd kilometers away, or maybe even more. And in a smaller tier 2 town where availability of a cardiologist is just hardly 10% of the overall cardiologist available. So this is the current problems. So how do we address to it? Smaller town, expensive treatment, lack of insurance, access to quality healthcare is not available, no timely intervention, and possibility of death in the transit. So here we come. We address these challenges. We acknowledge that these challenges are manifold, and let us address to these challenges. That's what we do in our center. We set up heart hospitals within an existing hospital in a tier 2, tier 3 city, in a space of just hardly 3,000 square feet of space. I set up a cath lab. I set up a coronary care unit. I bring in my own team of cardiologists and the critical care team to support that. Remote outreach centers, where we use this IoT AI-based solutions to diagnose an early problem. Again, to these remote outreach centers, how do I connect? We train and have a lab technicians deployed at these villages. We give them these devices. We tell them to connect to cardiologists in our command center across bigger towns. For example, I mean, I'm running a hospital in Rajkot, which is in Saurashtra, Gujarat. And I have a clinic in Supol, which is in the deepest part of Bihar. And I treat, I consult, and I advise a patient sitting from Rajkot for a patient at Supol. Likewise, in deepest Chhattisgarh, Naxalite areas, I do consultation. At least the patient with chest pain, the ECG is been done by a lab technician, and I have an AI which filters the normal, and the abnormal ECG comes to my command center. Even if I'm not available, my command center, I have a physician, MD physician available 24/7. If nothing happening there, it comes to me on my own personal phone. That too at a tat of hardly 2 minutes. And at least some clinician or a cardiologist advises the lab technician, yes, this patient has an heart attack. This is the basic loading dose. Please advise him to be taken and refer him to the nearest hospital. At least he gets that time. And the patient sees the cardiologist sitting in whichever part of the globe on an audio-video consultation. And we are launching shortly our consultation app with cardiologist, which is going to be available 24/7, and a cardiac technician at your home connected to our app. And our channel partners are, for my lab and my, pharmacy, we have these guys. So this is a simple schematic representation. Patient, early symptoms in a rural clinic, the ECG AI interprets, and other diagnostic parameters like blood pressure, sugars are being taken, fed into my, app, and, the doctors, the data engine analyzes these, secures it in the cloud, connects it to the team of physicians and cardiologists in my panel. Well, the app, which we're going to launch it shortly, well, it's going to be used in a tier 2 town where, the connectivity and the application availability of a technician at home is made available. So all these, been controlled with my heart command center, which is based right now in Gujarat, and we're going to start state-wise regional command centers in the next about 6 to 8 months. Well, after diagnosis, the patient is transported via the 108 ambulance, which are our channel partners. Again, we have our IoT devices in them, where our clinics are placed, so that the patient is monitored as he reaches the heart hospital. And the paramedic which are there at this 108 ambulance are being told what needs to be done and what not. You can see this remote video consultation. Just spend about a few seconds in this slide. Did you see this rural primary clinic? It's in a jhopda. It's in a thatched hut. once a month, any one of us goes there and we do a mass campaign. I have done. I've seen 100 patients in a day, and I've diagnosed 2 MI in that session. Patient has this Ayushman BPL card, comes to my hospital. And a PHC is 15, 20 kilometers away from this place. It's a population of just 1,000. I give employment to that local, population, whoever is available. We train them in our hospital. We tell them how to use this, simple tech-based on their smartphone and on an Android application. We tell them how to take an ECG. So we're employing people of that small village. We are empowering them with the technology usage and creating a value, a small impact which is created. A chest pain patient easily diagnosed comes to the hospital and he doesn't spend. Ayushman Bharat supports it. Well, the story so far, we have 1 cath lab with 4 outreach centers in Gujarat, with about 18 across India till now. The second heart hospital we are starting in Muzaffarpur, which is outskirts of Patna, where we have close to 7 clinics at this moment, and as well as in Gorakhpur, where the government has really helped us in giving us few villages to start off our primary, heart, chest pain centers and our telemedicine centers. So till date, we have close to, more than 30,000 patients we have consulted only in cardiology. And out of 30,000, I can tell you 500, I personally call them to our hospital in Gujarat. We have done an angioplasty for them. They could have, had some problems. And out of 300, 100 were primary patients. Primary is an acute heart attack, a STEMI protocol where the ST is elevated and patient can die any moment. So that 100 for me is my content. That yes, this IoT AI-based platform has saved life. So those 100 people, I can share those, testimonials which these patients have given us. Doc, and they don't have basic accessible healthcare in a population of just 700, 800,000. A simple smartphone can easily bridge this. And I'm in touch with various companies like, GE, Philips, Indian Make in India, ECG machine companies. Now, I've been talking to Jacky. He's been, having some innovative products. I said, like, amazing. Let's kind of collaborate on at least technology. We are hungry for people who can collaborate, at least do some, help us in iRead micro devices. At least let us add value to what, we've been doing. And AI, IoT is only going to enhance this. So the healthcare for tomorrow is going to be more on, value-based healthcare, how AI and IoT is going to spread that value to the patient, to our, healthcare. I mean, creating a value is the need of the hour. And again, making a business out of it. Well, Ayushman is phenomenal scheme with the government, where earlier in my days, about a year and a half back, I used to do about 40 angioplasties a month, about 150 patients angiographies. Now my numbers have doubled. It's like I've been funneling patients from these villages to my heart hospitals. My investors are happy. End of the day, we are creating a value chain. So IoT, friends, it has to be, thought about it, incubated in all these, business schools, brainstormed how a value can be created and how, a financial matrix can be, worked out on this. Well, a simple, we've been acknowledged by various forums. That's how Plexus is about, and how here we are to, have a vision of 1,000 clinics across India, rural heart clinics in villages and small towns, and about 30-odd hospitals, which we aimed in the next about 2-3 years, how, put this in shape. I thank you all. I thank Bhaskar for giving us that opportunity, and the organizers who have, called us, and I could have showcased my venture across. Please. Sorry, sir? Well, till date, it's our own money, and government is helping us in giving us the space in smaller villages and towns. The collectors of various villages whom I've showcased, they said, Doc, I will at least give you the space. 108 ambulance can provide me the logistics. Sir, I went to a village in Amreli, which is the rural part of Gujarat, 600 population. From that village, an army man, he has served in defense. He gave me his house. You make a clinic in my house. This is the stuff, I'm going to give you the food. He said, Doc, take 5,000 rupees I get out of pension. At least start something for my villages. Exactly. So I don't, so the money, yes, when we are offering some kind of an amazing, innovation, this is a disruptive model in a small village. People are acknowledging. And government is coming up with this Ayushman BPL cards. We are creating value. I mean, government has thought something for a longer vision, but innovation and IoT would bridge this. So this is the next future. And I can see, not even cardiology. I mean, I can have medicine. I can have, dermat, which was spoken about, and imaging, which is spoken about. There's lots happening in imaging as well. Like in a primary care, an X-ray is taken. Who's there to diagnose an X-ray? Audio video can even bridge that. Simple history, the AI will shoot a diagnosis, and after the AI, the radiologist can be connected in a small primary care for radiology. So something like this, there are a lot of innovations, but me being a heart doctor, I felt cardiology is where I can, do some, justice to what I've learned and give back to the society. I thank you once again to each of you. Thank you.
Thanks, Doctor, for sharing the success story.
Bhaskar?
Yes, Jacky.
I think it's the best sustainable model I ever saw. The best sustainable model. Because it's raised patients to the doctors, and he doesn't have to run after his patients. And with technology, you make everything more happy. It's beautiful.
So in the interest of time, we'll come to an end and we'll take the questions during the lunch. Thank you.
Thank you very much.
Thank you, Dr. Bhaskar. May I now request you to please give away a token of appreciation as a memento to all our panelists. Yes, please. Thank you. With this, we break for lunch, and we would like you to come back for the last session of the day at 2:30. 2:30, yeah. Thank you.